I could not live without pelvic physio. That is my thing.
My pelvic floor was non-existent after surgery, so that's when I saw pelvic physio.
To help relax a lot of the pain around, a lot of the muscles around the pelvic floor, and I find that quite beneficial.
The physio gives me exercises to do at home to help with the pain and muscle issues.
The internal physio was probably the single most helpful thing I've ever done.
No one recommend physiotherapy. I learnt ways to be able to help my pelvic floor relax.
It was kind of amazing to find out that I don't know how to relax my muscles.
I think about 80% of the women I see are either constipated or have extreme difficulty with evacuation, or they've got pain. Bladders are also involved. There's lots of urgency, sometimes difficulty passing urine, and then of course lots and lots of issues with the pelvic floor that I'm going to speak about. Sometimes external muscles, so the abdominal muscles, the hip muscles, the butt, these adductors, all of these muscles can be involved, sometimes with your pain, and you'll often be taught exercises and stretches. And we like to also now talk to you about the sensitive nervous system, and I'm sure Susan mentioned that this morning. So it's not only the organs that we're interested in. These are obviously very, very important, but for pelvic floor physios, for us, often the common link, when you've got bladder issues, uterine issues, bowel issues, and sometimes external musculoskeletal issues, often this pelvic floor muscle down here can be a bit of a link when you've got persistent pain, and the usual scenario that we find is that these muscles become very overactive. So it's very different from the type of pelvic floor exercises that most people think of. They think of strengthening exercises, but we're usually teaching our patients to relax their muscles and sometimes stretch them. Now the pelvic floor gets in on this show because you have your pain, whatever it is for primary pain. Pelvic floor muscles can contract in response to your pain. Then that leads on to secondary pain, which is pain in the pelvic floor muscles, because if a muscle contracts too much, it gets very, very sore. You can have contraction in other muscles outside of the pelvis. This keeps the pelvic floor muscles contracting, and then it's a bit of a loop that just keeps going backwards and backwards, or forwards and forwards actually. And then you can move on to have anticipatory muscle contraction. So if intercourse has always been painful, you will anticipate that it will be painful, and so your muscles will contract before you've even done anything. So this is looking at the pelvic floor muscles. This is you or me laying on our back. Here's our bottom. Here's the pubic bone. Legs are out to the side, and we've peeled all the skin off. This is clitoris here, urethra, opening to the vagina and anus there. But this is the very superficial or surface muscles, and this muscle is right around the opening of the vagina. Look how close it is to the urethra. Then we go into the pelvic floor. We're looking from below. This is a bit deeper. So here again is your buttocks. Here's your coccyx. This is urethra, vagina, and now it's rectum because we're in further. All of this great big muscle here this is classically what everyone refers to as the pelvic floor, and it's about 3 or 4 centimetres into the vagina. Now this is the side view. We're looking now at the pelvic floor muscles from the side. If you and I are cut in half like this and we're looking in from the side, these muscles go from your pubic bone at the front right through to your coccyx at the back, and they form this lovely big sling that supports your bladder, your uterus and your bowel. So this is what they look like at rest. Then when they contract, what happens is everything kind of gets yanked forwards and upwards. So the water pipe gets squished up behind the pubic bone, and you need that so that you don't wee when you cough and sneeze. The vagina can come forwards, and also this angle between the rectum and the anus down here increases in its angulation. So this is necessary because it helps us hold on to wind when we're standing on the queue at Coles. And if you're busting to pee and you're sitting in a lecture like this, your pelvic floor muscles are tightening up to keep you in control. Then when you don't need to contract them, they all let go and go back down to their relaxed state again. But in women who've got, and I see men too, so men get pelvic pain, women who've got a decrease in this relaxation ability of their pelvic floor muscles, if the muscles are overactive, they stay in this contracted but kind of forward angulated state. So can you imagine what this would be like to have this on an ongoing basis? Now we're back to that first slide that we looked at from looking below. If you imagine that this muscle here and this one here are actually a V or a U shape, when these muscles contract, the bottom of this muscle flips up and the bottom here flips up like so. So these muscles actually turn into Ws. And that W shape of the muscle can occlude the opening to the vagina, make it difficult to pee and to open your bowels, and also make it difficult to have intercourse. So if these muscles stay overactive for a long time, what's the kind of end result of this? Well, we physios are always talking about movement and muscle and activity. Pelvic floor is voluntary. It's exactly the same as your biceps. It contracts, it holds, it relaxes, and it stretches. Completely normal physiology for the pelvic floor muscles to be able to do all of that. So we would see a decrease in this normal muscle activity. So the muscles don't really contract, hold, relax, and stretch well. They can wind up a bit, can be sort of sitting up in this contracted state, up on the third floor. Your brain normalises this because that's what it feels like for you. But in fact, these muscles might be a little bit wound up. They become tight, tense, bulky. They can become painful when they contract a lot. Plus or minus, you might have trigger points in those muscles that might be locally painful, or those trigger points can refer pain out. It can be on both sides or one side. And this all then leads to, difficulty with bladder function, so difficulty passing urine, and sometimes women can have pain, and difficulty opening the bowels and evacuating to completion, and it can lead on to constipation. Some people have pain. But from a vaginal point of view, if you have a reduction in vaginal function because of pelvic floor muscle overactivity, it can lead on to intercourse pain, so either inability to manage penetration at all, or inability to manage complete penetration, or inability to manage movement. You might not be able to get tampons in or out. Pap smears might only ever be able to be done with a tiny speculum or under GA, and you might have extreme difficulty with examinations, ultrasounds, and sometimes if you need to do stretches, you might have difficulty with dilators. And if it's intercourse that's the main painful issue, then that might lead on to avoidance, psychological and relationship issues, and then you can also have lots of other external abdominal, pelvic, and sort of hip muscle issues. So we've sort of talked about the pelvic floor muscles. There are other muscles as well. So there can be this symphony of muscles that all join in with the muscle over-tightening situation. But it's not only the organs, and it's not only the muscles and the joints and the tissues. It's really, in addition, we want to try and look for other things that can link these two, or these several factors together. And if we look at nervous system sensitivity, it might just help us understand things a little bit from a broader perspective. And if any of you here have got any of these conditions that we're just going to mention, these just suggest that you've got a sensitive system. So fibromyalgia, irritable bowel, chronic fatigue, jaw pain, painful bladder, restless legs, migraine, tension headaches, chemical sensitivities. In the history that might suggest that you have a sensitive nervous system would be when physios ask about your pain, you know, is your pain sort of down a particular pathway, or is it just here, or in specific areas? That's kind of, we can kind of try and work out where we think that comes from. But if it's very diffuse pain, like it's all over the place, if you flare easily, if there are unpredictable things that make your pain worse, you get a lot of pain with small movements, you have multiple sensitive areas, you have a laparoscopy and there's no reduction in your pain, or you only have a short-term or short-lived reduction in your pain. You might fear pain and therefore avoid activity because you fear pain, or maybe your thoughts are a bit negative and you look to all future events predicting that they'll be terrible and bad and that you'll have pain so that you don't do those. And those kind of things in our history taking might indicate to us that you are a bit sensitive. So we like to think of pain arising from a brain network. It's a little bit like a tree with lots and lots of branches and interconnecting branches. And it's a living tree, and this is what we now refer to as neuroplasticity, and people have heard about this a lot. It's kind of one of those in-words like superfoods and, you know, all of that stuff. Everybody's meant to be into neuroplasticity. But if you think of it from your pain experience, our brains are actually responsible for our tree, and pain is obviously a very individual experience. It's related to your, you know, sum of all your experiences, learning, expectations, the pains that you've had. And if we understand this neuroplasticity, it can give us a biological explanation for the persistent pain experience. And pain is actually produced by the brain when the brain thinks that you are under threat and need protection. So from a physio perspective, if you came to see us, we're hoping to kind of look for a balance between tissue treatments, so that's all the things we talked about before, and other sort of treatments or things that might address this sensitivity in the nervous system. So if we go back to the tissues, we'd be looking at normalising this pelvic floor muscle overactivity. We'd be teaching you how to do squeeze, hold, let go exercises, with the let go being the most important part of it. You may or may not need to do some stretches, may or may not need to use some dilators. You may or may not need to do some trigger point work externally or internally, and you may or may not need Botox injections as appropriate, but we'll talk about that a bit later. Hopefully we'd be teaching you techniques for penetration to increase pelvic floor muscle relaxation. And if you clench your jaw, your pelvic floor clenches. If you clench your hands, your pelvic floor clenches. If you breathe in, your pelvic floor breathes in and tightens up. So if you can use squeeze, hold, let go in stages for any penetration, so a pap smear, ultrasound, intercourse, tampon, it'll just make the muscles let go. Other tissue things we'd expect to talk about nerve protection, so maybe sit less, sit on a split cushion because of all those nerves in that area. Teaching you nerve slide glidey type exercises or stretches, external pelvic stretches and limb stretches. General exercise is really, really important for a whole host of reasons. But if you've got a lot of pain, and interestingly on the video that was on at the beginning of this section, it was really good to hear people talking about exercise, and one of the women said that exercise was one of the key things that helped her with her pain. But if you just use a 2 out of 10 guide for flaring, if your pain is manageable and you do some exercise and it only goes up by 2 out of 10, and then you can use strategies that bring it back down again, then that's okay. Physios would always address bladder and bowel and vaginal function and sexual issues as appropriate, and you may need to do some connective tissue treatments like skin rolling on your abdomen or other tight areas, and they're just myofascial techniques that you can be taught to do yourself. These are great stretches. This is stretching your adductor muscle, which is this one on the inner thigh. These can get really, really tight. And you can do this one in front of the TV with your bottom up against the wall and your back up against the wall. So bottom on the floor and back up against the wall and your feet in like a froggy position. This is a fabulous stretch for your adductors. This is a glute stretch, but we also get you to put your hand on your knee and push your knee outwards so that you can actually get those hip rotators stretching a bit more. This one's piriformis. We talked about that muscle before. You just sit in that sort of same position and try and lean your body forward. This isn't a stretch, but this is a lovely position to sort of get yourself into if you've got a lot of pain and you just want to chill out. It's called a constructive rest position because everything's supported, and it just puts your pelvis in a really nice position to take the stress off it. If you need to do stretches internally, you may be introduced to gadgets like these. They're called dilators or trainers or accommodators. There's no right word. People are very passionate about one word or the other. I don't know what a good word is to use to describe these, but they're plastic tubes that go into the vagina and you can do stretches with them. I never use glass dilators. A lot of people have got glass dilators. I don't think it's a great idea to put glass into your vagina. And if your muscles are really tight, what's your brain saying to you before you put them in? Oh my God, are they going to break? Sometimes, where this is at the public hospital where I work, I see really extreme vaginismus, and sometimes this is just one of those little, gel pens. Sometimes we can only get something that tiny in, and we start with little tiny weeny things like that to do stretches. This might be, how you do your stretches at home, propped up on pillows so that your head's supported. Maybe later on you can progress to up-night kneeling to do stretches. Now moving on to Botox, we've been using it at the Women's Hospital and beyond that as well since 2002. It's got many, many uses. Obviously most people know about its cosmetic use. It's been widely studied, and in pelvic pain issues it's a very powerful tool, but in appropriate cases. The indications are persistent pain, and primary indication in women who've got refractory pelvic floor muscle overactivity, spasm, or pelvic floor muscle pain, who've had a suboptimal response to early physio and stretches, who've still got significant pain, dysfunction, and especially pain with intercourse. It's not first-line management at all. You should be really trying some physio first for 3 months and then moving on. It's not a panacea, it's not a magic wand, it's actually a window of opportunity to get in and rehabilitate very tight and overcontracted muscles. It decreases muscle bulk, it decreases muscle overactivity, and it decreases pain. And they're the 3 things that we find are actually very effective. We've been using it at the Women since 2002, and we've got publications on a pilot study, a case study, an RCT, a longitudinal and pregnancy study. But it's expensive. It's actually as dear as poison because guess what? Botox is a toxin. It's done under general anaesthetic in hospital, so it's not looked at lightly, but in the right cases it's very, very effective. Single and repeat injections. It's not for women who are breastfeeding or planning a pregnancy in the 6 months following injections. It takes about 10 days to kick in, and by week 3 to 4 it's working really well. Officially it wears off by 6 months, but if you do really diligent dilator work and stretches, you can actually prolong the effect, and most people only need 1 injection. It has a very, very powerful effect on muscle pain, overcontraction and bulk. Side effects are very uncommon, but include bleeding and bruising, and this resolves quickly. Some people have a bit of transient difficulty holding on to wind, or they might be a bit more urgent for the bladder. You're not usually recommended on hypermobile women. These are the women who are extra bendy, who dislocate their joints easily, because you're already a bit extra stretchy, and if we put something down here that makes you even more stretchy, it can sometimes have, untoward outcomes. Manual or trigger point therapies might be involved. You may need to use some sort of wand in the vagina or anus to stretch out muscles. There are books that can, give you information about this. Then if we move on to addressing the sensitive nervous system, I think it's just if we have an early appreciation of the neurobiology of persistent pain, and that the brain is actually responsible for our pain experience because it receives the information, evaluates it, it interprets it, and it responds to the information. So the brain tells us whether something's hurting or not. And if early on you and your therapist understand that tissues and the sensitive nervous system need to be managed together, it can optimise your results. So you might use relaxation, mindfulness, and I know there's a psychologist talking about mindfulness after me. Deep breathing as a calming strategy. You may need to see a psychologist to do some CBT to work on negative thoughts and things like that. Sometimes too, doing range of motion exercises in pain-free parts of the body. So if you don't have pain in your arms, because all your pain's here and down your legs, even just doing some arm stuff that's called range of motion, so getting your arms to move through as much of an arc of motion as they can do, first thing in the morning, what it can do is wake up that sensory motor cortex in your brain, but also help extinguish those movement equal pain memories, which is what we want to happen. Sometimes Qigong can be useful, yoga, Alexander technique, Feldenkrais, Eric Franklin. There's a great web address here, yourpaceyoga.com. She's a pelvic floor physio from the United States who treats people with pelvic pain, but she is also a qualified yoga teacher. And if you get onto these TED Talks Adelaide, Why Things Hurt by Lorimer Moseley, he talks about that neurobiology of pain. This is his book. These two guys really did sort of get this ball rolling quite a while ago, and this is a great book written for the general public explaining about the brain and pain. This is also a fairly recent book in the last 6 months or so, Why Pelvic Pain Hurts, but it's trying to put that neuroscience perspective into persistent pelvic pain. And this is great. This is a really, really good book, Mindfulness for Help, Relieving Pain, Reducing Stress and Restoring Wellbeing. It comes with a CD and it's got an 8-week program in it. I was actually seeing a male journalist who had really significant pelvic pain, and he was pretty blokey. He played a lot of rugby league, rugby union, cricket. He was a runner. He was pretty blokey, and he was really, really struggling with the chronicity of his pain. And I just said to him one day, look, I really want you to give this a go. Just keep an open mind. I really, really want you to try this. And he came back after 4 weeks, and he was halfway through the 8-week program, and he just said to me, I've had a 40% reduction in my pain. And I wasn't expecting that. It just blew me away. So physio, we will always nag you about exercise. It's really, really important. It's good for your brain, your circulation, your joints, everything. Try and do something that's new and fun, that wakes up different bits of your brain and ignites new pathways. So maybe Zumba might not be good because it might be too fast and too groovy, but maybe there's something you haven't tried before. And if you can give something new a go, it's just waking up different bits of your brain. External stretches are really, really important. I always say to my patients, just use the hurt versus harm expression to yourself, because sometimes things do hurt. If you've not been to a yoga class for a month, you've been on holidays, you go back and you think, wow, that really hurts. Well, you've hurt your muscles, but you haven't harmed yourself. Use the pacing approach to things. Don't go too hard, too fast, too soon. 2 out of 10, if you flare by 2 out of 10, that's okay. Stop, do a pain calming strategy, continue, reassess. You should always be given self-management strategies, and this is what we call self-efficacy. TENS machines can be really, really good. They're just tingly machines with little electrodes that go in your skin, and apparently Aldi has got them at the moment for about $25. They were $50 and they weren't selling very well, and they've put them down to half price, so maybe check out your local Aldi. I often ask my patients to create a positives list. What are all the things you can do now that you couldn't do before? Your physio might work on posture and other external muscles, and of course, we're part of a team. Thank you.